Okay, objective versus subjective. Which is more important? I think both are equally important. Now, I think the second title in my talk, or maybe the second word or third word of the talk, it's outcomes. Everybody wants to talk about outcomes of this or that. What is an outcome? Well, an outcome is simply the end result of something. What is an outcome measure? How many of you deal with this term outcome measure in your work? I mean, I know I do. I'm always asked, what are the outcome measures of CPAP? Or what are the outcome measures of this or that? An outcome measure is just very simply the measurement of the end result of something that took place. Okay, we have the thing we're interested in, and we're going to measure what happened as a result of that thing taking place. Process. What is a process? A process is just something that is occurring, is happening, but is not yet completed. A process measure. Who's heard of process measures? Who deals with process measures? Who here is in any kind of managerial role? Then I guarantee you deal with process measures every single day. A process measure is a measurement of something which is occurring while it is happening and is yet not completed. So you're measuring something that is in some ways still occurring or is an intermediate step in a process of, in this case, care that might occur in a sleep laboratory. Let's talk about outcome measurements in sleep labs. So an outcome measurement in a sleep lab on a diagnostic study, and I'm going to divide some of these things into diagnostic tests and therapeutic tests. So what is an outcome measurement on the diagnostic side? Well, there's many things. I mean, it could be you have measured into sleep to be 60% of the total sleep time, or REM sleep is 25% of the total sleep time. You counted 85 apneas. That's a diagnostic outcome measure. You measured the lowest saturation to be 70%. That's an outcome measure. On the therapeutic side, CPAP final pressure equals 10 centimeters. The number of apneas at the final pressure equals 3. CPAP was accepted. You see where I'm going with this? So I'm really trying to start with these basic terms that people sort of throw around all the time: outcome measure, process measure, measurement of this, measurement of that, and sort of break them down into what we're really talking about. So we talked about outcome measurements in sleep labs. Let's talk about process measurements in sleep labs. 80% of patients completed the laboratory questionnaires. That's a process measure. The no-show rate is 10%. 75% of the patients were very satisfied with the staff. These are all process measurements. 65% of patients who have sleep apnea see a doctor about the study results. These are process measures. These are things that are happening sort of while the process of care, the event of care is going on. You know, you're having patients come in, you're giving them things to do. They're doing them some of the time, but not all of the time. Sometimes they show up for their studies, sometimes they don't. Sometimes they're very satisfied with their care, sometimes they're not. So process versus outcome, which is more important? They're both important because they're different. It's not that one is competing against the other. They're describing the entire entity of what happens when you interact with patients in what you do at your work. Which is more common? Which is more common when we deal with patients? Outcome measures or process measures? Who thinks process? Who thinks outcome? It's about split. Good. Well, I think it depends on I think when you're talking about process measures versus outcome, it depends really whose perspective you're taking. So on the process side, who's interested in process measures? Who asks you about, what is your no-show rate? It's your administrators. Do you think the patients care what your no-show rate is? Payers care about process. Clinicians sort of care about process. Patients don't care about process. To them, process gets in the way of getting to outcome. So if you're a patient, what do you care about? You want a good outcome. You came in there for a specific problem, and when you're done with the process, you want to feel like the outcome you got was what you need or desire or will live with because you know it's good for you. Do administrators care about outcomes? Yeah, they do, because they get judged on how well patients like the process, and if patients don't get a good outcome, then they blame the process. And the process is what administration managers are concerned about. Clinicians want their patients to get good outcomes. They're interested in process because they know that good processes have a better chance of leading to good outcomes. But if they're smart, they don't confuse process with outcome. Or at least they're able to say, okay, some of the things we do are really process, some of these things, and maybe these processes impact certain outcomes, but maybe they don't. And then payers, people who pay the bills, they're interested in outcomes too, because they want their customers to be happy that they're supporting things that lead to the patients doing better or feeling better or having a good result. Let's talk about measuring processes. So I just have a couple of examples here. Number of patients accepting therapy divided by the number offered therapy. That's a process measure, and you can measure that. I mean, that's something you can quantify. Percent of patients dissatisfied with care. Percent of patients using CPAP greater than 4 hours per night. Percent of patients getting antibiotics for pneumonia, to take a different context, within 4 hours. And this last one is an important process measure for quality of care in hospitalized patients with pneumonia, for instance. So this is one that, say, payers look at, Joint Commission looks at, regulators look at. I bring this one up because if you look at the big scheme of outcomes and process measurements, sleep is so far out in left field, or so far, we're not even in the same ballpark as, say, process measurement for pneumonia care or heart attack care or diabetes care. And these are things that, as the sleep field grows and I think and enters the mainstream of medicine, the process measurements that we define that say, okay, we know what we're doing, we're taking good care of patients, will it be important to define? And this, for sleep, at least for sleep apnea, some of these measurements have been somewhat defined and turned over to organizations that define quality of care, the National Quality Forum, groups like that, who go to professional societies and say, okay, you guys are interested in sleep apnea. Tell us how you measure when somebody is getting good care. And the sleep field has responded, but we are still so early in this process compared to other big important diseases that we have a long way to go. But I think it's important for people in the technology field who are really on the front lines of patient care, patient interactions in sleep labs, to understand that there are formal ways to think about the work you do on a daily basis that kind of informs what happens at much, much higher levels. Now, the last thing I have on this slide is most clinical quality measures are process measures, and they're not outcome measures. There are very few fields that have robust outcome measures. Most things are process measures. So you're in the hospital with a myocardial infarction, getting a beta blocker as part of that care is a process measure. Getting aspirin during an acute MI is a process measure. It may lead to good outcomes if you get these medications, but it's not the outcome itself. The outcome itself is, say, survival a year after having an MI. Those are much harder to measure because what happens is these patients, they leave the hospital, they go home, they move, they don't answer questionnaires, so we don't know what happens. But when people are in the hospital, in the acute setting of a process of care, you can measure what happens. So this is where the sleep field needs to begin thinking.